Welcome, everyone. Welcome to Champion the Cause of Chronic Kidney Disease. I'm Mary Funseth, and I want to let you know that I'm a quality advisor for Metastar in Wisconsin. We're one of the partners within Superior Health Quality Alliance. And today you're coming together in a very, I want to say we're a fairly informal classroom. This won't be your usual come and listen to a webinar, take the information and go back to your job. We're hoping that you're going to take the time to really engage with us, talk about the things that we're talking about today in this session, having an opportunity to work directly with Dr. Orville Campbell, a nephrologist, and as well as working together, all of you and those from Superior Health, to learn more about chronic kidney disease and what we really can do to help support our learning, our knowledge, each other, and especially the patients who are receiving care from you. So we're going to get started, and I'm going to share my screen, and initially you're going to see kind of everything. So someone let me know that you can see at least this part of the presentation up.
Yes, we can see.
Okay, that's great. So quite a few folks will be coming through the door at different phases, so we'll try to catch them up as we get going. But first, if you will share in the chat what you see here, your name, your title, what organization you're working for and with, and why. This is kind of a lot, but why are you interested in participating in this particular collaborative? And as you do that, I'll tell you a little bit about those that I know that are coming or will come eventually over the course of the next 6 sessions. Some of you are working right in a clinic. Some of you are working on a team. I think many of you are working in primary care. Now, there are a few others that have signed up to join us today who are quality improvement advisors who work for Superior Health or for Improve Health or parts of our other organizations in our partnership. And we also have some folks coming along today and hopefully in the next 6 sessions that they are health educators. They work within public health. They may work within their county departments. So know that sometimes it may seem that we're only talking to a clinic team, but know that we're not, and that we really want to get to everything that everyone is doing over the course of time. And at any given time after today and going forward, please send me some feedback or some questions or things you want to ensure that we address over the course of this time that we're going to have with you in the next this session and the next 5 after that. So hopefully you're all chatting in. I see that there are 7, 8 now chats. Please take the time to take a look at who's here with us today. It's really helpful to know who you're in the classroom with. And because we're in a kind of a big session, we're not able to chat individually quite yet. So keep doing that chatting. So this is a structured collaborative, and it's going to be a little bit less formal than what some of you may be familiar with, which may be an ECHO structured collaborative, but it'll be very ECHO-like, if you know what that is. I'm not going to go into that. But in the room, you're always going to have at least one expert in the field and someone that we have found that whether they work within our organization, bringing information to you, or outside of our organization and their collaborators and stakeholders. Now, not all of you necessarily know Superior Health Quality Alliance, and to save a little time today, we're not going to go into what in general is Superior Health Quality Alliance. We do ask you to go out to our website and take a look a little closer, but I'm thinking you probably know if you got our invitation to come to this. But we are going to talk a little bit about those who are guiding this structured collaborative, and we'll do that in just a moment. Our sessions each time will be this. We're going to have a welcome, we're going to have a polling question, then we're going to have a brief didactic presentation. And just to mention that pre-session work I asked you to take a look at was intentional so that when you get here, that we won't go into a long didactic, which means that we'll have more time to engage in your questions that you have and letting us know what exactly it is that you need to learn more about, because in the session, of course, we'll be our expert in the field. We will then, after the didactic presentation, move into the discussion, and then we'll talk a little bit about the next action plan and how the action plan this time was provided to you. And if you're just coming on, please go ahead and chat in your name, your title, your clinic organization and location, and why you're interested in participating with us. And again, you're seeing this format right now because I need to show you a few things before we get into the didactic presentation. So let's just quickly take a quick look at what I sent you via email. And this is your action plan for this particular session. And you would have received this via email. If you did not receive this, let me know so we ensure that we have your proper email, and or your teammates who asked you to come along also shared this with you. Each week, this will change, but the reason why we send it to you will not change. For your first session, we hope that you start thinking about who are the clinic champions or champion that's going to be leading this and talking with the rest of your staff. Now, this is called a clinic champion. And as I mentioned before, if you're not working in a clinic, you have some sort of team that's working with you around chronic kidney disease or some chronic disease work initiatives. So feel free to take out that word clinic and just simply, who is your champion? And it may simply be you. But if you can bring others along with you at the next session, great. If not, please bring this information back to your team, regardless of what type of organization you have. So as this week, we talked a little bit about, we want to know who you are currently screening CKD for. So hopefully you gave that some thought. And we also hope that you jotted down your process steps. You may have more than 5, but in this case, we started off with 5 and you would add more. But have this handy if you have completed this already, as we talk in the Q&A and the discussion portion of our session. And also just know you can also complete it after this session. So let's move back to where we were at. Just to remind you, we will be having our next in-person session again, like this one on the 27th of March. And 1 week ahead, I will send you your session 2 materials like I did in this past time. Our session objectives today are going to be about what is chronic kidney disease. You're going to often hear us say CKD. Who should be screened for CKD? And what are the factors for the progression of CKD? So let's just take a moment and let you catch up with your chatting in, who you are, and let's launch our first poll question. And technically it's 3 questions. So we'd like to have you answer all of these questions all at once, and then we'll end the poll. So we'll give you just a minute or 2 to do that. They're pretty simple. The first question is, I received the pre-session materials. Number 2, I reviewed the pre-session presentation. And number 3, how do you rate your knowledge of CKD? So we'll give you a few more moments to complete this poll. Right now, about half of you have completed it. Okay, we're going to end the poll and we're going to share the results. So it looks like of the people who completed the poll, You did get your session materials. A few folks didn't, some wasn't sure. And again, send me an email after the session and we can make sure that you're getting what you need for session 2 and also that you have what we sent for session 1. And those who had the time to take a look at the pre-session materials, great. And here you have who is here today. And this is going to also really help our speakers each week to know a little bit about, in what way that we will be addressing the materials. So Dr. Campbell will be able to see this information as well. So next, take a moment now and have think about this question. And before we go on to the next slide, I'd like to pause also this time to have Candace come on, and Candace Olson. She is a decorator, but Candy, I'm sure you're a great decorator too. Candace and Deb and Dr. Campbell, starting with Dr. Campbell, if you will please introduce yourself today. And just to let you know, he is our key presenter today. And I'll hand that to Dr. Campbell, hand it then to Candy, then hand it to Deb, and then we'll get going. So Dr. Campbell.
Hi, thanks, Mary. I am a nephrologist and internist by training, 25 plus years in private practice, transitioned to the business side of healthcare in 2017. I do have an MBA in healthcare management, lots of correctional healthcare history, UR history. CKD was a passion of mine. As a nephrologist in private practice, I did spend probably around 19 or so years as a medical director with DaVita.
Great, thank you. So Candy, you're next.
Sure. Hi, everyone. My name is Candy Coles. I am a nurse by education with about 20 some years of experience in end-stage renal disease, both home modalities and in-center as well as acute. And I also spent about 6 years in surgery doing access placement, internal access placement for dialysis. I've been with the network since 2016, and I'm the quality improvement director there. Nice to have everybody on. Thank you.
Amy. And last but not least, Debbie.
Hi, my name is Debbie Bowe. I'm a nurse that works for Midwest Kidney Network. I've been with the network 10 years. I was a dialysis unit inpatient and outpatient clinical manager for 25 years. And I've worked in dialysis longer than I want to tell anyone, but I'm really excited about getting this group together and working with Dr. Campbell and Candy and Mary on this project. Our goal is to find those patients to prevent dialysis and or slow down the progression. So I'm really excited for this series. Thanks, Mary.
Thank you. And yeah, big thank you to this team. They are working hard along with other colleagues to bring to you some great information and content and just opportunity to engage. So again, please sit back and enjoy. In just a moment, Dr. Campbell's going to share with us the didactic portion, and then we'll move into conversation. So I hand you over now to Dr. Campbell.
All right, thank you, Mary. I don't have any conflicts of interest or anything to disclose. I am the Vice President of New Business Development and Strategy for Improve Health. That's how I have a relationship with superior health quality. All right. The burden of chronic kidney disease, or CKD, is immense. As you can see, 1 in 7 adults has CKD, which is 15% of the United States population, 37 million people. When it comes to stage 3 or pretty moderate CKD, 5 in 6 adults don't actually realize that they do have CKD. More than 661,000 Americans have kidney failure. 468,000 of them are on dialysis, and 193,000 live with a functioning kidney transplant. Obviously, the number is greater that have a kidney transplant. Diabetes and hypertension are the drivers for CKD as well as ESRD. As we go throughout this journey over the next 5 talks, other than this talk, of course, we're going to see how we mesh taking care of one patient, not just for CKD, but also ESRD. So unfortunately, if the time comes that they will make that smooth and appropriate transition to ESRD, hopefully they start with a functioning access. They don't have to have a central venous catheter and start like most people do. Again, diabetes are drivers of this disease. If you're Black or African American, hypertension is in the driver's seat. The general population, diabetes is in the driver's seat. Next slide, please. As you can see, if you have CKD present, the hospitalization rates for you is significant higher than the general population with no CKD. When you look at the hospitalization rate, stages 4 to 5, including dialysis, is astronomical, almost 4.5 times what it is for the general population with no CKD. Next slide. Same thing for mortality rates. Mortality rates are very high for stage 4 and 5 in dialysis drivers. Most patients die of atherosclerotic heart disease, MI, if you do have CKD, especially on dialysis. Next slide. Comorbidities in CKD, 30% will have one comorbidity with no CKD. 70% will have at least one comorbidity if you do have CKD. And of course, the more you transition toward the higher levels of CKD, or the worse levels, I should say, of CKD, the more comorbidities you tend to have. Next slide. Again, we brought this out. Cardiovascular risk increases with CKD, highest with a GFR less than 15. But even if a GFR greater than 60, but less than normal, you can see the risk is still significant. Next slide. The cost, $84 billion a year is the cost for CKD. And that does not include ESRD or ESKD. They're the same thing. They may be different on the slide, same thing. $37 billion a year is the cost for ESKD. This is 1% of the Medicare fee-for-service patient population, but 7% of the overall Medicare budget. Spending. Cost increases with worsening kidney function. Not a surprise because of the comorbidities, whether it's myocardial infarction, loss of limb, the infections, the cost of dialysis. It can go on and on and on. Next slide. What is CKD, or chronic kidney disease? Here's the formal definition by KDIGO. All right. KDIGO says it's abnormalities of kidney structure, function, present for greater than, this is the key, 3 months, because you may have AKI and have a lot of things present, but again, it is for 3 months, and it requires one of the 2 criteria. Number 1, a glomerular filtration rate, or eGFR, less than 60. Or their markers of kidney damage, which could be albuminuria, proteinuria, or it could be tissue damage, histology, or an imaging. For example, if you do have a kidney ultrasound or renal ultrasound, you will see that increase in echogenicity on the ultrasound. Next slide. Here's a prognosis of CKD by GFR and albuminuria. If you look to the left of the slide, you see the different levels of kidney failure, or the different stages, we used to say. It goes from G1, which is normal or high. Again, high tends to be greater than 120 or 130, whether you're male or female, all the way to G5 with a GFR less than 15 or kidney failure. And the degrees go again from normal, mild, mild to moderate, moderate to severe, and severely decreased. So when we talk about moderate kidney disease or severe kidney disease, you will have an idea of what we're talking about. Now, looking at the albuminuria categories and the description and range, you see that it goes from A1, A2 to A3, A1 being normal to mildly increased, where you have less than 30 milligrams per gram, all the way up to severe A3, where the albuminuria is greater than equal to 300 milligrams per gram. Now, it can become confusing. What is proteinuria versus albuminuria? Technically, they're the same thing. Albuminuria is proteinuria and proteinuria is albuminuria, unless sometimes you have some other proteins like kappa chains. But again, to keep it simple, the same. But when we specifically talk about proteinuria, it's usually in the context of greater than 150 milligrams of protein per 24-hour period. So when you look at prognosis, the higher the G level, or the worse the severity of the GFR, and the higher the level of protein, you can see where you will get into the reds, which means higher morbidity, mortality. Next slide. What is creatinine? Creatinine is the breakdown of skeletal muscle mass and dietary protein intake, red meat, for example. It's released into the blood at a relatively constant rate. And it tends to be stable in stable kidney function. But as kidney function declines, whether it's acute or chronic, in this context, we're concentrating on chronic, the creatinine will be increased as it's not being able to be excreted in the urine. There are limitations, however, as of using creatinine as a marker. For example, muscle wasting in the cachectic, anorexic, in the individuals that are malnourished. Also in the weightlifter, which has a high muscle mass, their creatinine tends to be higher. Patients who experience amputation or who are on certain medication, i.e. trimethoprim, sulfamethoxazole, that drug is usually known to falsely increase potassium and creatinine. Next slide, please. What is GFR, or the estimated glomerular filtration rate? It's an estimated measure of the number of properly functioning nephrons that are actually, as you know, the filtering units of the kidney. It's the basic unit of the kidney. It is an automated reporting whenever you check the creatinine in most facilities. The only downfall I see of it that is really a pet peeve of mine, it usually reports it greater than 60. We know you can have significant renal disease if your GFR is 60. Remember, you're starting well over 90, between 120 and 130 male versus female. And so therefore, if you just say greater than 60, you can have significant renal disease, but there's this comfort level. And when I was in practice, I experienced that. I would see a patient when the GFR is in the 50s, but they say, but I was told for years I had normal kidney function. So how could this be? So we need to get specific to get a specific number. Next slide, please. Serum creatinine is used to calculate eGFR, of course. All right, use alone serum creatinine is not the best way to detect kidney disease, especially in the early stages. That's important to know. We mentioned a few things: muscle weightlifters, individuals who are cachectic, anorexic, or individuals who are malnourished. Also, individuals who are pregnant, they tend to hyperfiltrate. So therefore, it's not unusual someone who is pregnant to have a creatinine of 0.4 when they usually live at 0.8. So we have to realize that creatinine is important. It's a good marker, but it has its limitation. All right. A rise in blood creatinine levels is observed only after significant loss of function in nephrons, and I've modified their caveats such as pregnancy. Next slide. Age and gender impacts eGFR. As you can see, if you're 80-year-old female with a creatinine of 1, your GFR is 61. However, if you're a male, 40 years old, that 1 may mean a 98 because muscle mass and age impacts your ability to filter creatinine. Also, remember now, after the age of 40, you lose about 1% of your kidney function per year as a general rule of thumb. So if you're 80, you're going to have a natural loss of kidney function. Next slide, please. This slide just emphasizes, let's not get caught up on absolute numbers, the absolute creatinine, the absolute eGFR. Trend is just as important as the absolute level, and that needs to be done. When I was training at Emory, they forced us to do an eGFR and a creatinine chart, one over the creatinine versus time and an eGFR. So you're cognizant, when you're in a hurry, you're cognizant of the trend of the creatinine as well as the eGFR. Now with diabetes, you can have a GFR 21 day, and then you come in 2 weeks later, you may need dialysis. So it's not a smooth transition or decline with diabetes. Whereas with hypertension, that is a more of a predictable thing when you plot 1 over the creatinine versus time. But again, the bottom line is whatever way you try to do it, you need to have a trending graph in everyone's chart that has CKD. Next slide, please. Albuminuria, the presence of albumin, we said is a protein, or the level of albuminuria or the level of proteinuria, says there is kidney damage. Often an early sign of kidney damage is the albuminuria. Again, could be less than 30 milligrams per gram, or in the moderate range between 30 and 300. That's why the urine albumin to creatinine ratio is an important tracking tool initially and annually, or even more often as you track CKD. There's a risk of progression the greater the albuminuria, and when you go into the proteinuric states, especially nephrotic range protein greater than 3.5 grams for 24 hours, the more protein that excreted, the more damage to the nephron, and becomes a dynamic and vicious cycle. So again, tracking albuminuria is important. It is an independent predictor of all-cause mortality, especially atherosclerotic heart disease. Next slide. Other markers of kidney damage, all right? It could be structural, such as polycystic kidney disease. You need to look at histology sometime. Individuals with lupus, which they may present with hematuria. You may need to have a biopsy. Of course, electrolyte abnormalities, especially when the GFR dips below 30, you can start to see things like, for example, hyperkalemia, or potassium increasing due to the use of certain meds, increasing phosphorus in the blood, again, when the GFR starts to dip below 30. However, when the GFR dips below 60, that's when you can see early sign of renal osteodystrophy or bone disease. You may see the increase or the beginning of increase in intact PTH, which could be a sign that you need to pay attention to phosphorus levels. You need to pay attention to 25 vitamin D levels. Next slide, please. All right, before we go into who to screen, it's important we talk a little bit about the cystatin C. Creatinine is not the perfect marker, again, because of malnutrition, cachexia, or even obesity. Individuals who tend to be obese, the kidneys hyperfiltrate, so you may have an overestimation of the eGFR. So cystatin C, which is a protein made by all nucleated cells, it is not absorbed, or secreted, so therefore it's a great marker. It can be used to confirm CKD. For example, say you have someone that's significantly obese and the GFR is high, but you suspect CKD. Cystatin C can be used because that begins to increase when the GFR gets to be below 94. Now the GFR may be 93, but the cystatin C is elevated, whereas the creatinine level or the estimated GFR may be normal. So it's very important, just like albuminuria, if there's none present, but you suspect CKD, it is an early marker of kidney disease. The CKD epi equation, and I'll read the position of the ASN and the National Kidney Foundation. The task force recommended the adoption of the new eGFR 2021 CKD epi creatinine equation that estimates the kidney function without a race variable. They took the race variable around because we tended to overestimate the eGFR of Blacks and African Americans. So therefore, they had more advanced kidney disease than once thought. When is the CKD epi equation even more useful than the previously existing formulas? That would be when eGFR is greater than 60. Again, cystatin C is useful in individuals where the muscle mass may be lessened. Again, weight loss, malnourished patient, weightlifters, or in obesity. So, and also cystatin C, once again, may be necessary to confirm early CKD or to confirm CKD where there's confusion or a gray area. Now, who do we screen? Who is at risk? Again, really simple. Diabetes and hypertension, slam dunk, those are your drivers. But don't forget a great history in a physical. Let's think about a family history of kidney disease. Those individuals that are 60 or older, remember, you do lose kidney function naturally after the age of 60. Ethnicity matters. It's important to know Blacks or African Americans are 4 times more likely than white Americans to have kidney failure, and Hispanics 1.3 times more likely than white Americans. 35% of the dialysis population is Black or African American. Remember, they represent 12% roughly of the general population, so they are overrepresented in dialysis. And also when we look at kidney transplant, there's a barrier at every turn for individuals who are Blacks or African Americans. They're less likely to receive a transplant evaluation, less likely to receive a transplant. They spend longer on the transplant list. They're less likely to survive on the transplant wait list. They have lower rates of graft survival on the post-transplant, so a lot of health equity. Let's not forget HIV, Hep B or Hep C, and even COVID-19 of recently, which has a particular histology that looks like focal segmental glomerulopathy. We don't want to make you nephrologists, but know that COVID-19 has a specific collapsing form of glomerulonephropathy. Next slide, please. Again, delivering culturally competent healthcare. We just talked about that, about who's more likely to end up with kidney failure. We just want to spotlight ACE and ARBs. It's long been thought out there that ACE and ARB should not be used in Blacks or African Americans because they don't work. You may have to use larger doses, but they do work in individuals with diabetes and proteinuria. It's very important that rumor or myth is dispelled so individuals can get the treatment they need that's effective, that's appropriate, and to diminish health equities in the system. Next slide, please. Risk factors for progression, again, we talked about it: albuminuria, proteinuria, poorly controlled diabetes, AKI that goes inappropriately treated can lead to progression of underlying CKD. Again, hypertension, one size does not fit all. We need to have a standardized way of checking blood pressure in our office, and we'll talk about that later on in another talk. You don't just sit the patient down and just take the blood pressure. There should be a standardized way of taking blood pressure. Of course, lifestyle issues such as smoking, obesity. I don't like it on the lifestyle, but it's listed there because some people are obese for different reasons, not just lifestyle. Metabolic acidosis, let's not forget genetics such as polycystic kidney disease. Next slide, please. And we're at the end. Questions?
Yes, please feel free to open up your mics at this time, or you can chat these things in. I will cover the chat at this point, and it's very important that we get your questions that you have brought today. Who would like to kick that off?
And if we don't get questions, we'll just go through the list and just start asking questions. Is that okay? No, I'm just kidding.
Yeah.
I'm just kidding.
Yeah. Well, and we also will take a look at the action plan. So, but we'll give everyone a moment to open up your mic. I see a lot of muted folks.
And remember, there are no silly questions, dumb questions. This is a disease that's fraught with a lot of morbidity, mortality. Cost is a huge variable, but if we take care of these patients, then we won't have to worry about cost. Maybe we can share. Anyone, you don't have to speak, you can share in the chat.
Is there a difference in the prognosis between an elderly patient who has natural deterioration in renal function? So if that's a natural course. In terms of the implications for that, is it any different if the deterioration is due to aging versus other causes?
Yeah, there's usually a difference because there usually other comorbidities, because they would not have the vascular changes, based on hypertension, diabetes. They wouldn't have the same inflammatory process because the CKD secondary causes is usually being driven by something inflammatory like diabetes or maybe something genetics like polycystic kidney disease. So there is a difference based on the presence of those other comorbidities that are present.
So would I shoot for less than 130/80, for example, in an elderly person where there is no other contributing factor to their deterioration in renal function versus somebody who has a contributing factor?
Wow, that's a big can of worms you've just opened, because really we should shoot for, a systolic less than 125 if you have a standardized way of measuring blood pressure. In other words, the individual has been off caffeine for 72 hours. You wait at least 5 minutes till they enter in the room. If you're going to do manuals with a manual cuff, or you're going to do automated, you're going to do automated with a cuff that's calibrated. In other words, you have a written plan for measuring your blood pressure. There are caveats to that less than 125 over less than 80. The caveats would be significant things like frailty, postural hypotension, and we're developing a dashboard that would list these things. Another big thing would be carotid arteries, significant carotid artery stenosis that may need surgical attention, or they may not be candidates. You would actually have to be careful. Of course, age greater than 85 as well. But barring those caveats and a standardized method of measuring blood pressure, we should shoot for lower blood pressure, systolic blood pressures, like less than 125. Systolics, again, we should shoot for less than 80. The caveat, you should try to avoid less than 50, or be careful in those individuals that come to you with a baseline diastolic blood pressure less than 50. So again, barring caveats, the lower the better. Lower systolic blood pressures are less associated with cardiovascular events. So that's why I said it's a can of worms based on all the caveats. But great question. Thank you.
It is a good question, Dr. Jones. And I just wanted to mention to you and to everyone on the call that I will be sharing with you. We have, first of all, one course that may be helpful to your team as far as training to take a good blood pressure and the mechanics of doing that well as we do have another structured collaborative going on at the moment, but will probably be happening again. And we'll most likely have some recordings from it, but it's how to set up a good blood pressure management program with patients. So it's additional information that we will definitely share with you.
Mm-hmm.
Dr. Campbell, we have this question. What is the frequency of monitoring of eGFR and albuminuria for the various stages of CKD?
There's a chart, because as you go to more advanced renal disease, the monitoring shifts from annually to actually, in some cases, monthly. Looking at if someone has stage 5 eGFR, you wouldn't want to do that every 6 months, monitoring blood pressure and eGFR. You'd want to see those patients almost on a monthly basis, preparing them, making sure that really earlier they hadn't been getting sticks in their non-dominant arm, blood pressures in their non-dominant arm, to making sure that you're doing dietary education, making sure that you're doing access selection. So when they start, more than likely, hopefully, if they're not going to do home hemo, or preferably home peritoneal dialysis, whether it's automated or manually, then at least they will start with the arteriovenous fistula, which is the best way to start in their non-dominant arm, as far up the arm as possible, to give you a chance to go down farther on the arm. So yes, so it depends on, is your blood pressure controlled? Is your eGFR stable? It depends on a lot of things. So again, there is a chart that we've developed that we're going to make available to give some guidance. But again, what makes the difference between a good CKD program and an average CKD program would be, how do you manage and screen people when they get into the door, identifying risk factors, and how do you deal with the caveats in the treatment? That's the difference between a good and an average CKD program.
So there was a follow-up to that particular question. I think you've pretty much answered it, but let me state it just in case. If you see rising EGFR and albuminuria in spite of optimized blood pressure and blood sugar, what are the other options for management? Do you feel like you covered it, or?
Yeah, if you're ever out of your element, out of your expertise, always refer to a nephrologist. Again, it may not just be the EGFR level, but it's the rate of the decline. If you see a rate of the decline that's significant, and you've maximized blood pressure, the A1C is something else may be going on, especially if you're seeing rising albuminuria. That could be a sign that I need to have this patient biopsied, which would be the decision of the nephrologist. Go ahead and refer. Again, I always tell individuals, if you are out of your area of expertise, regardless of a protocol, go ahead and refer the patient so they don't experience the complication of ESRD.
Thank you.
And you mentioned the kind of disparity that's created by measuring or having different cut points for GFR in the African American population. So would you advocate that we really just use the standard non-African American GFR for everybody?
I would use the CKD epi equation for everyone,
okay,
as a general rule of thumb, especially in those individuals with a GFR greater than 60. Again, if there is concern that there is CKD present that you can't put your finger on, then do go ahead and use that cystatin C, especially if the individual may be malnourished, for example, weight loss, whatever the reason. If there's a gray area but a high suspicion of CKD, go ahead and order the cystatin C. Definitely in obese patient, especially moderate to severe, go ahead and get that cystatin C if it is available, because again, obesity or even significant proteinuria in a diabetic, their GFR tends to be overestimated due to the increased glomerular pressure, and it causes hyperfiltration.
thank you.
And not to call out one of our participants here, but I know that she's part of a group, a county system providing public health education. And I would encourage all of you to consider, information like that is something you can turn around and create something in a patient-facing document as well, just to share with the folks that you are serving. Because as you know, patients are really should be encouraged to be their own advocate, and they need education as well. So talking this over with your patients is great. Talking it over with your team so that they understand what you're learning today. Very, very important. And we really want you to kind of like spread this across your team, as well as think about ways you can turn this back around to your patients. Before we'll save time for a little bit more education, but I just want to quickly call out the action plan that we had for this week. And bear with me for a second. So in this session, it talks a little bit about what you learned as far as it explained what you were going to be learning today. What we're hoping that you'll do is, who is that champion within your work that you do, whether it is a clinic, you're a health educator, your team that's creating resources for others, whoever that is, start thinking about who those champions are. And if they're not at the table today, make sure that you're sharing this information with them. One of the participants today said that they're looking for workflows. This is great. And that's what we're going to be definitely bringing to you over time. Something that you can do in order to begin that progress to improve protocols and workflows is go out and seriously take a look at who exactly are you screening? Who are you screening the most? And definitely this checklist here can help you. The third thing that we put on your session planning document, your action plan, is step back and take a look at what is your current process in the steps. Jot it out simply, bring it along with you to these sessions, and then start writing in the margins where you want to make some improvements, because I think you're going to learn some things along the way that will help you improve that process. And again, bringing ideas to the table as we gather, and also simply, improving as you move along. Any questions on that in the action plan?
I have a question, but it's before the action plan.
Sure.
Okay. So we talked about some risk factors for CKD, but are there any protective factors that are relevant to our discussions here that might be helpful? It's sometimes nice to have a positive health model to go off of as well.
Absolutely. Absolutely. Exercise, even mild conservative exercise like walking, and we should consider the minimum 150 minutes of walking. And it's doing what you can. It doesn't have to get your heart rate up 150%. It's been shown that GFR improves with even just mild exercise, just moving. And if you can't move a lot, then stand sometimes. Even we who work remotely at a desk, get a standing desk. They're not that expensive, and spend probably half of your time of that 8-hour day standing at a stand desk, of course, and that helps. Also, not doing certain things like avoiding smoking, those things help a lot. Also, eating a less inflammatory diet, skewed towards plant-based as opposed to red meat. Those things also help vascular disease, because when we think about vascular disease, we think about the heart, but don't forget tiny blood vessels like in the kidneys, they suffer from a disease before the major vessels. So you can have small disease of the heart, and you can also have small disease, blood vessel disease of the kidneys as well. So those are some ways that we can do that. Also, urinate on a regular basis. Don't go more than 2 hours without urinating. There's a reason why on bus trips, the bus stop every 2 hours, right? Because you need to empty your bladder whether you feel like urinating or not, and so on. Avoid things that give you UTI like that, proper hygiene, those kinds of things. And again, maintaining a good weight. And even if you are over weight or obese, whatever, just weight loss. It's been shown that, a 10% weight loss, total body weight loss, is very healthy in terms of energy, less cardiovascular event, but also, again, the closer you are to your ideal body weight, the less you overwork the kidneys. All right. that's all I have.
In terms of
Okay.
yeah, and in terms of
Thank
the
you.
screening, for those, you mentioned, gave a list of risk factors that should lead to screening. Is that if when you do a screening, the GFR is normal, is that once a year or is that more or less frequently than that?
More frequently, if an individual has advanced, a moderate to advanced kidney disease, or if the person has AKI, or if the person has unstable labs. But someone that's stable with moderate or less kidney disease, then annually. And again, we have a chart that we're going to give to you. And later talks, we'll talk about management so we don't end up going down the road of management. Today, we're focusing on those individuals just walking into your practice or who exist in your practice with risk factors. We need to get them screened. We need to develop metrics. What percentage of our diabetics have a urine or urine albumin to creatinine ratio? What percent of our patients with hypertension are controlled? Barring the caveats, do we have a standardized way of measuring blood pressure? And are we intensively controlling blood pressure? So it's all about screening today. And we need to develop metrics in our practices that everyone comes into that wide funnel, but they need to come out at that narrow end to make sure we're not missing anyone. If someone is significantly obese, have they been screened? Do we have a good family history of kidney disease, or we just focus on heart disease, diabetes? Do you have anyone in your family with kidney disease? This is a very good question to ask. Is our history and physical, is that process robust enough, or do we need to make it more robust?
Thank you. Please keep chatting in your questions, and we'll make sure that Dr. Campbell gets those after the session, and we'll make sure that we return those answers to you. But I want to quickly, as we get to the end of our session today, first of all, thank you all. You're all very attentive, and it's been very helpful. And Dr. Campbell, your presentation has been spot on as always. But if you'll all bear with me just for another quick couple of seconds, because we're going to be using these tools going forward, and I think it'll be great information for you to get this quickly here. We are going to not only come to you every other week, we're going to continue to send you those pre-session materials, and also as we kind of learn today some stuff and things that come through our conversation, I'm actually going to send out some additional materials to you so that you have some post-session one things and so on each time we meet. But in front of you is Superior Health Connect. Some of you are aware of this with Superior Health Quality Alliance, and some of you are not. We have a network of knowledge that we want to have you join us in if you want. Totally optional, but I think you'll be happy to take a look at this at your leisure. I'll send out the link again, but tell me, did my screen change?
Yes.
Okay, great. When you arrive to this learning management system, you will be able to find a wealth of information, and it's something that I'm going to let you peruse around on your own. But I wanted to call it out today to ensure that you all know about it, and you will be invited to it to join just in general in our network. But next week, I'm going to be introducing your very own group within that area. And in that group, we will be putting session materials along with continuing to send them to you, but it'll be a place for you all to engage and continue to learn together. You'll have a chat option so you can talk to each other, and this group will have a group within there. Quickly moving on, just so you know, we have some additional things coming up that you may want to pay attention to, and we can get this information out to you, or you can find it on our website. We have some very quality webinars coming up, and this Back to Baseline and Beyond. We hit a lot of topics that I think would fit your staff and for you. I also want to call out, when you do join that Superior Health Connect, you will find a particular course that is very helpful with chronic disease. And again, I'm not going to take too much of your time to go through that. But please go out and take a look at it if you'd like. And know that we have a Shine the Light on Stigma campaign. And in this information, we'll cover this again in our next session, but again, you'll find it on our website for Superior Health. But we do want to call out this and hoping that your organization will consider simply taking a pledge. That's what it is. It's a very serious pledge. We're not asking you to do anything other than that, but we're also asking you to consider learning more about stigma when it comes to behavioral health. And with that, we have come to the end of all the session materials for today. A lot. A kickoff is always a lot, but Gray, would you please put the survey in the chat? Please take the time to complete the survey. And beyond the survey, please send me some recommendations of things that you'd be looking for in our next sessions. We'd be very happy to work things through because again, this is your learning and we want to make this exactly what you're looking for. So thank you all for your attention today. And again, we're going to keep this open for just a little bit so you can all click on that survey. And we look forward to seeing you in the next session, which happens on March 27th. Be looking for the session materials 1 week prior. And again, we are all available for you. So just send us an email. We look forward to hearing from you. Thank you. Bye-bye.